Did you deal with anything more ordinary than bubonic plague?
After my residency, I was transferred to a 35-bed hospital, including bassinets, and ambulatory care clinic, primary care only, in Winslow, Arizona, which also served the Navajo population. And there wasn't a psychiatrist on the entire Navajo reservation. There was a town about 60 miles away that we could send patients to get a psychiatrist consult, and then they were seen in our clinic by a social worker. And so our medical director came to me. I maybe been there 6 weeks or so, and he said, "Lynn," he says, "I feel really uncomfortable with the psychotropic prescribing." He says, "I don't know anything about it." He said, you know, the social worker is sort of looking over this stuff after the meds are prescribed by the consultant. "I want you to review and approve all the prescriptions for psychotropics." And I said, "Okay, Dudley, sure." Well, all I knew is what I'd had in pharmacology in pharmacy school. I knew that phenothiazines were a three ring structure, you know, but I didn't know a whole lot clinically. And so I started reading a lot, and I started interacting with the patients, and really became really fascinated by the disease states and how they affect people and how they affect people's lives, and in particular at that point in time with the disease schizophrenia, and just the devastating impact that it has on people's lives. You know, pretty much for about 80 to 85% of people are diagnosed with schizophrenia. You know, they have a lifelong illness, and with exacerbations and sort of a downward course over time. And even though our treatments have improved, they're still far from perfect.
So is it fair to say that this is what led to your career in psychiatric pharmacy practice?
It's the reason that I decided when I went back to my advanced training that I would specialize in psychiatry. And you know, the other thing that I learned, particularly in Winslow, where we were really quite isolated, you know, 4 or 5 physicians, 2 pharmacists and nurses, and a couple of lab techs, was that you don't need fancy buildings and expensive technology to provide good healthcare. You need people that really care and are committed. And I also learned the importance of interdependency and relying on one another, and really learned about team-based care before it became a fad. The foster care system in the United States is that when children are taken away from their biological parents because they're unable to care for them for a variety of reasons. Sometimes it's substance abuse, sometimes it's mental illness, sometimes the children are physically or emotionally abused. They're put in with families that are referred to as foster parents, and so these children, because of the situations that they came from, and they're taken out of their families, end up having, you know, a much higher incidence of emotional and mental problems than other children, and they typically come from impoverished families as well. And we also know that low-income people are at higher risk for mental disorders as well. And in the press in the state, there were a number of journalist investigations of inappropriate prescribing, and in fact, in one of our state agencies started looking into the prescribing through the state Medicaid program, which is our public assistance program for poor people, and foster children automatically receive those services when they go into foster care. And there's a real problem with just way too many medications being used in children at the same time, sometimes as many as 8 and 10 and 12 medications. And so in 2003, our state legislature directed the State Health and Human Services Agency to develop a task force to come up with recommendations to how to address the situation in terms of looking at the care of children in foster care that had mental disorders. And I was on that task force, and one of the recommendations was that we put together a multidisciplinary committee to develop prescribing parameters for children that were in foster care. And so we released those in 2005, and we've updated them every 2 or 3 years since then. In fact, we'll probably start another round of updating later this year. And in 2019, when that version was updated, the state agency decided to expand their use, not just for children in foster care, but all children that were receiving mental health services through the state Medicaid program, again, the state public assistance program for healthcare. And we saw over time that the use overall of psychotropic medications decreased, the use of drugs within the same therapeutic class, same mechanism of action decreased, as well as just the total number of medications decreased over time. Now, with all the stresses during COVID, that's tweaked up a bit, but it's still much, much lower than it was when we rolled this out in 2005.